Welcome back, fellow mitochondriacs, for another episode of Cancer as a Mitochondrial Metabolic Disease. So, we are heading towards the end of this little micro series talking about ways, strategies to lower blood glucose and essentially relieve or remove the availability of glucose to the cancer cells, correct? I mean, they're going to try to absorb 10 to 30 times more than a normal cell would try to absorb. And when we have high blood glucose levels, we're going to have a lot more available pool for them from the pick from. So therefore, part of the strategy is getting your blood glucose down to as low as possible while raising ketones as a way to lower the amount of availability to the cancer cells as a first line kind of treatment. That's the therapeutic ketogenic diet, that's intermittent fasting, that's et cetera, trying to use that as a first line tool. The issue that we have been running across is that, you know, it's not uncommon for people to be insulin resistant, to have prediabetes, diabetes, be overweight, obese at the time of diagnosis, and therefore, even being on a ketogenic diet, even when they're doing the best they can, following it to the best way they understand, even doing some aggressive OMAD or intermittent fasting, people are not able to get their blood glucose down to the level they need to get, which is what prompted this part of the series, because I wanted to give as many tools in our tool bag as possible. Now, do I admit that the literature here is not perfect? I admit that the literature here is not perfect. The literature here that we're showing, A1C drops, fasting blood glucose drops, insulin drops, et cetera, is going to be mostly seen in people who have diabetes. The studies are done in people who have diabetes. And so therefore, will the effect that a lot of these interventions and compounds have on a person who, let's say, is not quite diabetic, maybe they have an A1C of mid fives, like 5.4, 5.5%. They're not in that pre-diabetes or diabetes range, but they still need to get their blood sugar down substantially in order to hit the targets we're looking for in terms of blood glucose on average, as well as GKI. So no, it won't be exact, but it's pretty much the best we have. And I would say that we could probably extrapolate the majority of this, looking at the most powerful interventions we've seen so far, and extrapolate that to being the most powerful for people who are not diabetic, truly, or just having a trouble getting to that level that they're getting to. That being said, we're going towards the end of, what we're able to find at this time, of things that can be helpful. And I wanted to cover the first topic on the last video, but because the prebiotic fiber, beta glucan talk the last time went so long, I wanted to hit probiotics in the last video, but we weren't able to. So I'm going to start off by talking about probiotics and, balancing the gut microbiome and its effects on our blood sugar. Overall health, to a slight degree. I want to make sure I don't completely put it in a vacuum of just blood glucose, because there's all kinds of other beneficial effects that are happening from being on probiotics. But that being said, I do want to hit it from the lens that we're trying to look at it from, which is basically from a blood glucose glycemic control, and specifically looking for studies that look at A1C, hemoglobin A1C, because that's going to be our average blood glucose over about a 3 to 4 month period. It's going to be kind of the gold standard of looking at how your blood sugar is doing on average, right? So that's what we're going to be doing today. I'm also going to kind of talk about some mind-body practices that have been shown to have profound effects on blood glucose, A1C. And then what I wanted to do was, because even though we covered exercise, being able to steal glucose and glutamine away from tumors, we never actually looked at it from the lens outside of the mechanistic, kind of way of looking at it, of what are the actual effects of exercise in terms of glycemic control. So I wanted to compare and contrast, because when I was somewhat surprised by how effective the mind body stuff was, and I was like, well, how does this compare to exercise in general? So I wanted to compare and contrast that. So that's what we're gonna be doing today. So we left off on this slide here, talking about beta glucans from, in this study, was looking at oat beta glucans, but we looked at a variety of different sources of beta glucans and even kind of talked about maybe what the better sources would be, whether it be medicinal mushrooms or whatnot. Today, we're going to talk about, instead of prebiotic, things that feed probiotics, we're going to talk actually about the probiotics themselves and some of the mechanisms of actions they believe is taking place in the gut microbiome, and then subsequently the systemic, kind of holistic person, how that looks. So this paper was fairly recently released in August of 2024, and it says the role and mechanisms of probiotics, supplementation, and blood glucose regulation, a review. And it says here that probiotic supplementation is a microbiologically based approach to the treatment of type 2 diabetes mellitus, which can achieve anti-diabetic efficacy through the regulation of different tissues and metabolic pathways. In this study, we summarize recent findings that probiotic intake can achieve blood glucose regulation by modulating intestinal flora, decreasing chronic low-level inflammation, regulating glucagon-like peptide 1, GLP-1, decreasing oxidative stress, ameliorating insulin resistance, and increasing short-chain fatty acid content. And I picked this paper not only because it's a recent paper, because it had a bunch of great graphics that help us understand the mechanisms of how this potentially works. So it says here that the role and mechanism of probiotic supplementation and blood glucose regulation, it has the pathogenesis of research status of type 2 diabetes mellitus, the challenges and the regulation of blood glucose by probiotics, future development, applications of blood glucose to blood glucose, and then the role of mechanism of probiotics and blood glucose regulation. And it says here, improving intestinal flora, just like it said in the paper, regulating GLP-1, lowering inflammation, oxidative stress, insulin resistance, raising adiponectin levels, as well as increasing short-chain fatty acids. And, there's a very complex dance that's going on between systemic circulation and the intestinal microbiome. And, a lot of us have heard about the, gut-brain axis, and that's definitely taking, there's definitely a relationship here between the gut-brain axis, because the gut-brain axis has a lot to do with the signals of inflammatory signals, oxidative stress signals, and then hormonal and kind of neuroendocrine signals that are being transmitted between the gut and the central nervous system. But there's a bunch of other signals too. So for example, one of them is a kind of a gut-brain axis looking at appetite regulation, short-chain fatty acids, and other neurotransmitters that regulate appetite. And then the gut microbiome is also changing intestinal bile acids. It's promoting gluconeogenesis and glycogenolysis. It's having roles on insulin sensitivity and reducing inflammation, which can help make the beta cells actually have better performance. And then reducing insulin resistance at the level of the muscle, regulating insulin-related signaling signaling molecules in the muscle, and regulating the intestinal microbiome and as a whole, which is important for immune function and just function as a whole. So probiotics are pretty unbelievable. And if we look back at mechanisms of how the prebiotic fibers worked, a lot of the way that they worked was through the gut microbiome, right? Feeding the right bacteria that are allowing us to lower all the things that probiotics are doing. So you're going to see a lot of overlap here. Where you will see some differentiation probably is where a lot of the fibers, they can have, a slowing effect on the gastrointestinal absorption of foods. It can also have even enzymatic, what do you want to call it? Enzymatic, inhibition of some of the enzymes that break down glucose, so that way they're not being absorbed by the system or being absorbed in a more slow route. But a lot of the ways that it works upon was within the gut microbiome. So a lot of this is going to be a little bit, superfluous or overlapping at minimum. So we see here that when we ingest probiotics, you're going to have the metabolites that the probiotics are going to put off, and that's going to have effects on the intestinal cells, and then glucagon-like peptide, and then glucagon-like peptide is going to increase glucose uptake within fat cells, decrease glucogenolysis, or the making of new glucose within the liver, increasing glucose uptake in multiple systems in the fat cells, in the heart, in the muscle cells, in the pancreas, etc. And it's going to then lower the amount of glucose needed to be made by the liver because it's being uptake better, and it's going to realize that we have glucose on board because the insulin resistance is being overcome. And then on top of that, it's going to delay gastric emptying, similar to probiotic fibers would, increasing satiety through some of these brain chemicals as well as decreasing glucagon secretion, which is the stimulator of gluconeogenesis in the liver, and reducing the reabsorption of glucose within the kidneys. And then it's going to help because through the inflammatory cascades and oxidative stress cascades, it's going to actually help beta cells proliferate and actually survive and have less apoptosis and just, like I said, survive. So that way, the more insulin when it's necessary to be made. It's not like it's making more insulin because, we want to increase insulin. That's not actually, that wouldn't be a really necessarily a benefit unless it's necessary. And part of the issue, as we talked about in the past, is that as the pathogenesis or the creation or the process of diabetes is being formed and set up in the body, part of the issue is that the beta cells in the pancreas, the cells that make insulin, they actually end up dying off. And then no matter how low our carbohydrate diet is, or good our diet is, we actually lose the ability to make insulin, which is a big problem, which makes us to be insulin dependent. And that's a big problem. So what's cool is a lot of these compounds we've looked at actually shows that it protects the beta cells and even in some cases regenerates beta cells. So that way we can actually put out insulin in the quantities needed, not more than needed, but just in the quantities needed to help improve insulin signaling and insulin resistance. Another way of looking at it is when we, this is why I love this paper, because it has such great graphics, right? So we have probiotics, they're having an effect on the, the colon and the colonic intestinal microbiome. And it's going to, through short chain fatty acids, through other mechanisms as well, it's going to have effects on toll-like receptors, which are, kind of like part of our innate immune system. Lipopolysaccharides will be decreased, which is a big stimulator of our innate immune system, and can lead to massive amounts of inflammation, which can actually dramatically change our mood acutely. As a matter of fact, I don't have it here, but it was a really interesting piece of literature that I saw when I was doing my functional medicine training, and it was where they convinced some participants, I think they may have been medical students, to inject lipopolysaccharide or LPS into them, and then they check their inflammation levels, and then they check their mood and their motivation and things like that. And it was like within hours, inflammation went up, their mood went down, their motivation went down of being exposed to this LPS. So lowering LPS, through the brush barrier or through the border of these intestinal cells and decreasing permeability is critical to maintaining our moods. Even, the inflammation can by itself, steal away tryptophan to make kyurinate and steal it away to make, neurotransmitters that are important, like serotonin, and which are important for mood. So there's a really neat, part of the gut-brain axis that's being highlighted here without saying, by LPS and TLR4 being down regulated or less activation, less gut permeability, less inflammation. As you can see here, less TNF alpha, IL-1 beta, IL-6, IL-8, and increases in IL-10, and then increases in glucagon-like peptide and PYY. So peptide YY. So it just shows that there's multiple mechanisms. If that wasn't, enough seen here, where we have other mechanisms that probiotics have on ways that improve our health as an overall, but also improve our blood sugar capacity to handle blood sugar and our insulin resistance. And you can see that it seems to be there's a lot of power in what the potential power with all these mechanisms on deck here. Now the question is, when the rubber meets the road, where are we looking at in terms of a glycemic improvement? Well, let's take a look. So there were two meta-analyses that I was able to pull. There was one from 2020, and it was titled "Improvements in Postprandial Glucose Control in Subjects with Type 2 Diabetes, a multi-center, double-blind, randomized, placebo-controlled trial of novel probiotic formulation." And it looks like that this was a 12-week, in general, a 12-week study. And I'm sorry, this first one's not a meta-analysis. It's just a double-blind randomized controlled trial. Excuse me. And it looks like there was a 12-week study. One group got a placebo. One group got this probiotic blend, and this probiotic blend had a lot of the probiotics that a lot of us have heard about over the years, things like bifidobacterium and Akkermansia, as well as others. And it looks like that when they were given this probiotic, just the probiotic, that's the only thing they did different for 12 weeks. And it lowered their A1C by 0.6%, which is, we're talking like greater than berberine, greater than, several of the interventions that we've talked about over the last several weeks. So pretty powerful. Now, again, this is just one study. How does it look like when we look at it into a meta-analysis? And that's what I was going to look at here in this 2022 study. And it's titled "The Effects of Probiotic, Prebiotic, Symbiotic Supplementation on Blood Glucose Profiles: A Systematic Review and Meta-Analysis of Randomized Controlled Trials." And it looks like there were 39 trials that were included in this meta-analysis, and all patients had diabetes in this trial. This is why that's not perfect in terms of how it applies to all of us, because there's going to be patients who have cancer that don't have diabetes. But I'll digress. And what I'd say is that it looks like it lowered the A1C by about 0.59%. So that's completely in line with this 0.6% decrease in A1C from a probiotic for 12 weeks. So not too bad, really. Is it as good as some of the prebiotics by themselves? No. We looked at particular psyllium had like a 1% decrease in A1C on average, which is pretty amazing. Fibers like inulin and beta glucans weren't quite as good. It was like 0.6% about, so it's closer to the probiotic outcomes here. But still, I mean, I'd be curious to know what happens if you did like a inulin beta glucan psyllium combination with one of these, powerful kind of like glucose targeting probiotic blends to see, if you could have a synergistic effect. So I think that would be the next thing that I would like to know. I'd also like to know, like with most of these studies, how well do these interventions do in people who don't have diabetes, people who are, again, in that normal range, but still not in the range we'd want them to be for metabolic therapy. How much of an effect does it have on those type of people? That's another thing I would like to know, but we don't have that information, unfortunately. So I'm going to take the next portion of this video in a little bit of a different direction. I'm going to talk about kind of the way that I was taught early on in my functional medicine days to look at disease. Okay. So I stole this graphic from one of my mentors, Dr. Dan Kalish, who I respect highly. I took an amazing course from him early on in my functional medicine days, right after I graduated residency. And I got a lot out of it. And what I'd say is that this is probably the best way that I have seen to organize how we look at disease from an integrative functional medicine perspective. And what I'd say is that, this is never an exhaustive list, okay? And this is not a complete list, but it still gives us a great understanding of how we end up in a place we're at. So let's say hypothetically we have not sugar cravings, but let's say we have hyperglycemia. That's the reason why someone comes into a doctor, a symptom, right? That doesn't necessarily mean that, we're in mainstream medicine, we generally will treat symptoms, right? So this is what we're talking about. We're talking about a symptom of a disease, right? This is the tip of the iceberg, right? And what we do in medicine is we give you a treatment for that symptom, right? And so in this case, let's say we give you a medication that lowers your blood glucose, but it doesn't necessarily fix the problem, right? It just lowers the blood glucose, makes the numbers look pretty, and kind of keeps the rest of the iceberg under the water hidden, and doesn't get to the root causes, right? And so in order for you to have a symptom, some part of our body has to be fundamentally broken, right? Like it's not functioning adequately to keep the symptoms, at bay. And therefore, some of these systems are broken down. Now, Dr. Kalish, in this particular graphic, he used neuroendocrine system, the GI tract, and the liver. I think it's just a whole, it should be every organ system as being part of this, including the kidneys and heart and things like that, brain. But my point is that some part of the system is broken down. And then what he had, and again, I've added my own little things to this, but he added was what he called the 4 horsemen of disease. And that was inflammation, chronic low level inflammation, catabolic physiology, which is changes in hormones in a way that make us into breaking a breakdown mode, and then insulin resistance and oxidative stress. So that's what he called the 4 horsemen. And then these are things that we can detect quite easily, okay, in the bloodstream, but it doesn't tell us exactly where it comes from. So if I check an HSCRP or an A1C in someone, and I can see that they have insulin resistance and chronic elevations and inflammation, it doesn't tell me where it's coming from. It just tells me that it's there, right? So this is stuff we can detect quite easily, okay? And this is kind of where we generally stop in a lot of areas of medicine. We see it, and then we are like, okay, let's hit it with a symptom blocker, like a steroid, or we hit them with insulin or a medication of some sort, or an NSAID or something to block the inflammation, right? We don't necessarily get to what we need to get, right? And that is the underlying root cause, right? And when I was a younger, more naive functional medicine doctor, I used to believe there was one underlying root cause, but in reality, there's like dozens of root causes, and we probably have a synergy of them going on, creating a milieu of these 4 horsemen that leads to breakdown and symptoms. Now, I've added a couple of things here. So I've added mitochondrial dysfunction here and here, because ultimately these things can damage mitochondria. Mitochondria can increase these 4 horsemen. The 4 horsemen can then further damage mitochondria, and then mitochondria, when they're damaged and the bioenergetic decline happens, that can lead to organ dysfunction and subsequently symptoms that are created. So I kind of made this, I would say, new and improved from my perspective. Now, the reason I've circled catabolic physiology, because I want to try to go over that to explain why I believe there's such a profound effect on the next intervention that we're talking about as a way to lower blood glucose, okay? So going through a little bit of physiology here, we have the HPA axis, right? The hypopituitary adrenal axis. And when we have any stressor, okay, that could be literally any stressor. That could be me driving to work, nearly getting cut off by somebody who's driving like a madman, and having a stress response. It could be me having a code blue on one of my patients in the hospital. It could be me, having any part of stressor. And same as you, right? You're going to be under any kind of stressor. That could be a food stress. That could be EMF. That could be light stress. That could be any stress, right? That stressor is going to activate the HPA axis, okay? And that is going to lead to elevations in catecholamines and elevations in cortisol, okay? Now, I want to go through a little bit of why that's a bad problem, okay? So again, why is catabolic physiology one of the 4 horsemen according to Dr. Kalish? Well, the reason why is because when we have chronic elevations in cortisol, okay, we can actually steal away substrate from the sex steroids, okay, that'd be testosterone, estrogen, et cetera, DHEA, and that can have its own downstream effects of having androgen deprivation or sex steroid deprivation and hormone dysregulation in other axes apart from cortisol, okay? In addition to that, it can also have direct effects on the HPT axis, the hypopituitary thyroid axis, okay? So it can damage the thyroid axis as well, okay? So it becomes where it means cortisol dysregulation. But what it ultimately happens is, because cortisol has profound effects on other hormone systems, it's going to have effects on your sex steroids, it's going to have effects on your thyroid hormones, et cetera, et cetera. If that wasn't bad enough, it has also effects on other tissues, okay? And the more extreme examples of this is called Cushing's disease or Cushing's syndrome. But I'm going to take a walk through what happens when cortisol is increased when we're under stress, okay? And so it's going to decrease growth hormone secretion. It's going to decrease muscular mass. It's going to decrease glucose uptake into muscles. It's going to decrease glycogen synthesis. It's going to increase catabolic physiology, okay, breakdown of muscle tissue, and it's going to decrease new muscle protein synthesis, okay? So that's a problem, because a lot of the mechanisms of how we've seen how exercise works, how a lot of these compounds work, is that it increases glucose uptake into muscle and increases glycogen synthesis in muscle and in liver. So therefore, cortisol is like the exact opposite of that, okay? It also breaks down bone. It decreases beta cell function and incretin effects on beta cells. It decreases incretin secretion by the gut, and it also increases glycogenolysis or makes new blood sugar. So, one of the things that's pretty cool about human physiology is that we have multiple systems to help prevent um, us from having hypoglycemia. Okay. So cortisol and catecholamines are one of the ways that we protect against low cortisol or low blood sugar. But when cortisol is high, when it doesn't need to be high, it raises blood sugar. And it does it through all of these mechanisms we're talking about here. It increases the creation of new glucose within the liver. It increases insulin resistance, and it also has profound effects on the actual fat tissue as well. So, needless to say, stress is a big deal. And as a matter of fact, I'm going to skip to a little bit down to the bottom before I hit catecholamines. Stress management is actually one of Dr. Seyfried's presses, right? So this is why he puts it here. Now, I think this is a little bit vague because, again, stress can be literally anything, right? It can be psychological, traumatic, electromagnetic, infectious, allergic, dysbiotic, xenobiotic. Any stressor, right, can activate the system. And I think that when you put stuff like stress management, it makes someone automatically think meditation and things like that. But stress management is also inflammation management. It's also oxidative stress management. It's also blue light management. It's also EMF management, right? So my point is that stress management is a key pillar within the Press Pulse protocol. And I want to mention that because my belief is that is how a lot of the mind-body interventions actually functionally work. Okay. Now, before I don't want to completely miss this. So in addition to cortisol being released when you're stressed, you also will have releases in catecholamines through the sympathetic nervous system, the fight or flight nervous system. And so when we activate the sympathetic nervous system through a variety of mechanisms, we are increasing blood glucose, we are decreasing, pancreatic function, and we are having effects on, again, the amount of glycogenolysis and gluconeogenesis is happening because these are backup systems to protect against low blood sugar. It's just that when we're activating the sympathetic nervous system, we're in fight or flight mode all the time because of the stress we're under. We're increasing our blood glucose and we're increasing our decreasing our insulin sensitivity, but increasing our insulin resistance just by being under stress, which is, again, why Dr. Seyfried puts stress management as part of the Press Pulse protocol. And I think it's rightfully so. I just want to add that it doesn't have to be just getting in a fight with your significant other or getting cut off on the highway. It can be multiple areas that can lead to a stress response that you may not even be aware of. Me being exposed to blue light at night at the wrong time of the day is a stressor. Okay. So that by itself likely can raise blood glucose without even eating through these mechanisms, through these stress mechanisms of cortisol and catecholamine release. So I do think that apart from the actual physical exercise that's happening in some of these practices, I do believe there is a stress reduction that's happening because when they tease these out in meta-analyses, okay, this is really the best study that I could find on these interventions and having an effect on lowering blood glucose and lowering A1C. And unfortunately, it's behind a paywall. And so I couldn't get the entire study to look through it and kind of pick it apart. But I'll do the best that I can here. So what I'll say is that you can see here that when you implemented a mindfulness-based stress reduction, that's like a mindfulness-based meditation. Okay, by itself, meditation has blood glucose lowering effects similar to that of berberine, stronger to that of vitamin D, vitamin K2, and several other minerals we looked at. It is powerful, and it has, this is how you tease out, okay, what portion of qigong or yoga is just the actual stress reduction part of it, and it's likely at least half of the benefit is probably from the stress reduction. Okay, the lowering of cortisol, the lowering of catecholamines, and those effects on our body, right? That's why stress reduction, again, is in stress management is part of the Press Pulse protocol. So this meta-analysis showed that, let's see here, mindfulness-based stress reduction was about a 0.48% decrease in A1C. It looks like that Qigong has about a 0.66% decrease in A1C, and yoga having about a 1% decrease in A1C. Now it further said that meta-regression revealed that for every additional day of yoga practice per week, the raw mean A1C differed by 0.22%, which means that again, if I could look through the study itself without having to pay $50, I would like to do that, because I would like to see, on average, to get this 1% decrease in A1C, how many sessions of yoga were they doing per day or per week, I should say. I mean, if you took it just off the face value of 0.22%, you'd say, well, they're probably doing somewhere between 4 and 5 days per week. But I don't know that for a fact. It's because it says an additional day of yoga practice per week, right? So does that mean it's like 3 days per week, and then any additional was a 0.22% above and beyond that, which means that if you did 5 days per week, would you be looking at like a 1.44% decrease in A1C? Seems like it's possible. So I would like to get a little bit more into that study to give you more benefits, or to give you more clarity in that. But my point is that these mind-based, mind and body-based interventions are part of them, like qigong, and part of them, like yoga, are going to be based off of the physical activity that you're putting your body through, right? And there's going to be benefits to that, as we're going to compare and contrast to just general exercise. But there's also just the stress reduction part of it through the mechanisms that I'm trying to lay out here with the cortisol and the catecholamines like norepinephrine and epinephrine. When we're under stress, that's being at play here, because that's been shown by just the mindfulness-based having a profound effect on A1C at 0.48%, similar to, again, berberine. So we're talking like pretty good amounts of blood glucose response just from that itself. Now, I wanted to get into, how does this compare to exercise? Well, one of the more recent meta-analyses that I could find was exercise and insulin resistance on type 2 diabetes mellitus, a systemic review and meta-analysis. And it says here that the mean difference of fasting insulin was negative 1.64, and HOMA-IR 0.14, fasting blood glucose was 5.12, and A1C was 0.63%. And I was thinking to myself, well, does that really like look at exercise as a whole? And is this really like giving us a good picture? Because that seems a little bit low to me for exercise as a whole, right? So I found another paper that was published in 2024. And even though it was a randomized controlled trial, it kind of did its own literature search and gave us some interesting information. So I only pulled this because I wanted to show the paper that I published, or that it was published in, and it was Effectiveness of Structured Exercise Program on Insulin Resistance and Quality of Life in Type 2 Diabetes Mellitus, a randomized controlled trial. And I clipped out the portion of the study that particularly looked at glycosylated hemoglobin, or A1C, because, like it says here, it's the gold standard measurement of glycemic control. And it says here that our findings are consistent with those in the existing literature. A Cochrane review by Thomas et al. Provided a reduction in A1C about 0.6% with exercise, which was both clinically and statistically significant. For studies with a duration of less than 3 months, the decrease was 0.8%. And it says that some studies spanning less than 6 months was about 0.7%, which is consistent with our study findings, which is a little bit confusing because it's saying that exercise as a whole is 0.6% decrease. But then if it's less than 3 month intervention, it's actually more of a benefit. And then if it's 3 to 6 months, it's 0.7%, which is still better than exercise as a whole, which is, again, a little bit confusing. Now, our findings were supported by this Buell et al., who reported that exercise reduces A1C by approximately 0.99%, which is considered an adequate and reduction in glycemic control. And I was like, okay, so what are they doing different in this study that they got a 0.99%, nearly a 1% decrease in A1C compared to the overall, lay of the land? And it kind of breaks it down here, showing that several studies have compared the effects of aerobic and then resistance training exercises, and concluded that aerobic exercises are more effective in reducing A1C levels. A systemic review of by this group here reported that a reduction of A1C of about 0.73% and 0.57% with aerobic and resistance training, respectively. Okay, so if you're doing aerobic mostly, you're going to get about a 0.7%, 0.73% on average decrease in your A1C, which is more than you would get with resistance training, which is about 0.6%, which is what's seen in the meta-analysis here with exercise as a whole, right? Well, then they broke it down here and they said, okay, another study found that A1C decreased by 1.33% with aerobic activities, 0.55% with anaerobic or resistance training. And then when they combined them, they saw a 1.75% or 1.74% decrease in A1C. So I would, again, no study is God, and you have to really pick through this stuff to really get to the nitty gritty of what they're trying to show and trying to actually what are included and how often they're exercising, how much are they exercising, what type of exercise they're using to figure out what this average actually means. Okay. I mean, if you exercise, you're going to get an benefit. Okay. You're going to get a benefit of about 0.6%, but it seems as if in some studies, you're seeing that if you do a cardio based, regimen plus weights or resistance training, you're going to get a synergistic benefit above and beyond what you would get with one or the other, upwards of about 1.74%, which would be, frankly, the strongest intervention possible that we've seen in all the things we've looked at, whether it be red light therapy, whether it be various supplements, minerals, et cetera, et cetera, et cetera, probiotics, prebiotics, exercise of both aerobic and anaerobic and resistance training seems to have the most effect or the most potential benefit of lowering your A1C. Now, let's look at that, what that may look like, okay, on a graph. So let's say you lowered your A1C by 1.74%. Let's go back up to ancient history here to that graph that I pulled a while ago. So let's say hypothetically we were at 10.7%. We'll round down. And we went down to 9%, right? So it'd be 1.7%. So we went on to 9%. That would be like having an average blood glucose from 260 down to 212. Let's use a different example. Let's use 7.6% down to 6%. That would be going from an average blood glucose of 170 to 125. Let's say you're in the pre-diabetes range when you start this metabolic therapy business. You're at 5.9%, and you go down to, or let's go to 5. Let's say 5.9, and we go down to 4.2, which I think is probably unrealistic, but you're going to go from 123 down to 74. Okay. So now we're well within the range of where we need to be with metabolic therapy, just with exercise alone. Okay. Hypothetically. So I think that I wanted to share that because, I ultimately, I want to give you as many tools in your tool bag as possible. And these tools, although they can be used, just like keto can be used in a vacuum, just like Dawn can be used in a vacuum, or Minbendazole or Fenbendazole can be used in a vacuum, or HBOT or IV vitamin C can be used in a vacuum, they don't work as well as they should if they're used in combinations, right? So the same goes with these strategies and tools we have in our tool bag to lower our blood glucose as a way to get our blood sugar down to that magical less than 80 value and our glucose ketone index down to that magical 1 value, so that we can implement these other therapies that can synergistically affect the cancer cells and lead to the type of outcome we're looking for using metabolic therapy for cancer. So I hope that helps. I want to look at some of these comments. So people who have access to Dawn, are they millionaires or something for this costs even something like 10 milligrams? Well, yeah, man. What I would say is that I think it's more of anything. It's a supply and demand issue, right? There's a very little supply because there's nobody hardly making it at all. And if they're making it for tiny quantities for like lab experiments for animals. So therefore, when they try to dose for a human who's much larger, requires much larger dose, you're getting paid ridiculous prices, right? So I can empathize with that. What I would also say is that I don't want to demonize nor or villainize nor deitize Dawn, right? Like I think that blocking one enzyme in the glutaminolysis pathway is a little bit short-sighted. So blocking GLS, the glutaminase enzyme that Dawn blocks, only is probably adequate, or is probably necessary but not sufficient. I think blocking it along several pathways, both uptake, utilization at the GLS enzyme and the GLUD enzyme, is also probably going to be important. And using multiple compounds to hit that would be probably critical. I think also we could look at other compounds that are not quite as expensive that also have effects on the GLS enzyme, such as mebendazole, betulinic acid, berberine. There may be one other one that I can't think off the top of my head that blocks the GLS enzyme. And then I think also having the synergistic effect of blocking glucose up or glutamine uptake and utilization at multiple steps is also going to be a way that we can maybe even use lower doses of DAWN or other medications that block specifically GLS as a way to get a synergistic effect at a lower price. And then hopefully as this becomes more popular and more mainstream, the supply will increase as the demand has increased, and that will even out and it'll make the price go down. That's the best I can say with that. How effective is kefir? Is it the right type of probiotics? So I don't know the answer to your question. I think that probiotics from whole foods is probably for general health purposes, the best way to get them in. And kefirs and yogurts and kimchis and things like that. I'm not saying I like those things. Specifically the kimchi or the sauerkrauts and stuff like that I'm not a huge fan taste wise, but I think that those are the best way to get them. I think when we're talking about metabolic therapy and trying to lower your blood glucose, I would not want to add any carbohydrate foods to my mix. So therefore I think that maybe supplemental probiotics may be a better option in those kind of situations. And I'd want to be using, of course, the ones that the organisms that were studied and those to try to replicate that, right? So you know, the Akkermansias, the bifidobacteriums, the lactobacillus, those type of bacteria, which are in those formulas that have the effects in that on that study to show the 0.6% decrease in A1C over a 12-week period of time. I'd want to focus on those. And on top of that, the probiotic supplements shouldn't raise your blood glucose because they don't have a food attached to it. So therefore, you may get another bang for your buck of not having any increased glucose load to the system. Sometimes I wonder when having a probiotic is the right one. Yeah, I agree. I think it's the Wild West. If you want me to be honest with you, I think there's a lot we don't know. I think we're just at the tip of the iceberg when it comes to microbiome and probiotics and prebiotics, and understanding the mechanisms and also understanding the combinations and what is dysbiosis and things like that. I think we have a lot to learn there. So should aerobic and anaerobic be done in the same workout session, or should it be broken up? And if so, when should it be done? Can aerobic be done in one day and then anaerobic the next day? Wow. I don't propose to have expertise as like an exercise physiologist or an exercise science. I'll explain what I understand. What I'll say is that I don't think most people who are not like on like anabolic, support will be doing probably resistance training every day. I think that what I've seen from people who are more natural, like kind of bodybuilders and natural fitness enthusiasts, is that like a whole body workout, like 3 times per week, is like sufficient. And I like their variable resistance from bands personally. I use an X3 as well as other kind of like band systems. Does that mean I don't like free weights? No, I used to be a power lifter. I love free weights. I also like cable machines or cables as well. But I'm about to hit 40 in about a couple of days here. And so therefore, like, I am looking at, longevity and preservation of my joints. And I just feel better when I use resistance training as a full body and using variable resistance from bands. I think that the question about should aerobic and anaerobic be done in the same workout, that's like an age-long question that I don't think anybody can answer. I think that I'd have to defer you to like exercise physiologists on that one. What I can say is that I do believe that you should be using instead of like smoke breaks. Like, I'm a big fan of like light breaks, of going outside several times throughout the day to set my circadian rhythm, but also exercise breaks throughout the day. So like small bouts of like, walking, getting your steps in, but like systematically broken down between like before and after a meal would be like probably more beneficial to just doing one long, 60-minute walk, in my opinion, because we can use exercise as a way to acutely lower blood glucose before and after a meal, so that when we eat our meals, we can kind of like minimize glucose and insulin spikes. So therefore, like for some people, I'll have them walk outside before and after a meal to minimize their glucose spikes, being in the sun, and getting the benefits of red light therapy as well as exercise at the same time. For people who live in northern latitudes and northern climates who don't have the ability to walk outside because it's freaking cold outside, I have been recommending people like walk in front of like a red light panel or doing some kind of exercise in front of a red light panel as a way to get a synergistic effect of the red light and the exercise as a way to lower blood glucose to minimize that effect on when you eat your meal. So that's kind of how I've been approaching it. Exercise to the point of producing lactic acid will be converted to glucose, the problem, according to Dr. Seafried. Yeah, I think extremes of anything, is probably a problem. I think that in general, most studies show exercise having major benefits on cancer immunity, on cancer, fighting cancer. So therefore, I think that you have to be looking at like extreme levels of exercise to probably be a problem for that. And I don't necessarily recommend that or propose that or take part in that myself. I don't know if I agree with what you're saying, staying away from huffing and puffing state of exercise. I don't think I agree with that, actually. I think that the amount of lactate that's being produced in aerobic conditions is probably minuscule, and it's going to be cleared out by the Cori cycle pretty quickly, or it's going to be converted locally back to pyruvate and not glucose, but pyruvate to be used in functioning mitochondria. So I think it's probably not a problem at all. I think it's overblown. The lactate that we're talking about that's problematic, it's in the tumor microenvironment and it's in the very local microenvironment, and it's kept there as a metabolic shield away from chemo, away from radiation, away from our immune system, et cetera. And the pH is so much lower than physiologic pH. It's not even funny. We're talking like 6 to 6.5 pH, which is much less than physiologic pH. I'll also say that I check lactates regularly on patients with cancer, metastatic cancer, who come in with infectious diseases and stuff like that to the hospital. And I don't routinely see people's lactate be elevated above and beyond normal if they have metastatic cancer just from having cancer itself. Now, if they have septic shock, different story. That's a different reason to have lactic acid elevation. So I don't think it's a big problem, frankly. I think actually, I would even say that avoiding exercise is probably a reason why your blood glucose is not where it needs to be, and you're probably shooting yourself in the foot to some degree. Again, avoiding extreme forms of exercise. Walking 45 minutes 3 times a week. Yeah, I think walking, as long as you can tolerate it, I would do it daily, and I would break it up. I would try to hit a 10,000 step goal per day, which the classic way of looking at it is you can get about 1,000 steps for 10 minutes. So that's about 100 minutes of walking at least per day. I think it makes more sense to be broken down, at least before meals, maybe before and after meals, even as a way to, lower blood glucose, as I was saying earlier. 22 Fahrenheit, sunny outside. Oof, that's brutal. I'm sorry. That takes a lot of fortitude to do that. Took a 10-minute walk in a t-shirt. Oof. Get outside regardless of the temp, stress on the body and mind. Do no harm doesn't mean it won't hurt. I agree. I think that there's definitely like the hormetic stressors that you can get. Just be careful. I don't want anybody catching a cold or getting pneumonia or hypothermia. That's pretty much what I have to share today, you guys, for strategies for blood glucose from probiotics and from mind body and even looking at exercise a little bit deeper than we've looked at in the past the conceptual ways that it helps cancer, but looking at kind of it's more kind of effects from a numerical standpoint. I have a couple other tricks up my sleeve. I want to talk about cold, the use of cold as a way to steal glucose away from cancer cells. And I want to talk about deuterium depletion therapy. I don't really know where it fits in to this discussion of cancer, but considering that I saw that it has effects on lowering blood glucose and A1C, in addition to its other anti-cancer effects, it seems like this would be the time to talk about it. And it's something that I'm really excited about and can't propose to be an expert in. That would be like a Laszlo Boros or a Gabor Sommelier, personality. And I do refer you to they have several podcasts that they have put on. And of course, Gabor has a couple of books called Defeating Cancer and deuterium depletion therapy, I think is his most recent one. But that would be the expert advice when it comes to deuterium depletion therapy. But I do want to talk about it because I think it's something that I talk about in my courses. It's something that I've seen in a variety of alternative cancer spaces, including one of my mentors, Dr. Jack Cruz. And so therefore I'd like to talk about it in context of lowering blood glucose and how it fits into, kind of a anti-cancer strategy as a whole. I'm going to answer one more question here. It says, wintertime, okay to take oral vitamin D, calcidiol. Look, I think that it's a mistake to have a low vitamin D level if you have cancer. And as a matter of fact, I push people's vitamin D level up as high as I can get it without causing any significant hypercalcemia, which I do believe is a theoretic side effect of high blood vitamin D levels, because there's probably no one that I know of that checks more vitamin D levels on patients. Not only do I do it as an outpatient, but I do it as an inpatient on almost every patient that comes in the hospital, and especially people who have cancer. And so therefore I see a lot more, probably 99 times out of 100, it's a deficiency or a insufficiency compared to, a high vitamin D level. But I do see it on occasion, a high vitamin D level. And, one of those common tests we check in the hospital is called a comprehensive metabolic panel, or a CMP. And a CMP, we get a calcium level and we get an albumin level, which is what's necessary to correct a calcium and get a true picture of your calcium status. And I would say probably 1 out of 10 calcium or vitamin D levels greater than 120 nanograms per milliliter, I have seen a person who have a borderline or a high calcium level. And I would be very curious to know, as you mentioned in your next question here, K2 and magnesium, is that person who's taking massive amounts of vitamin D, are they taking vitamin K2 along with it? To see if that's at least part of the reason why that one person out of 10 who has super high vitamin D levels has a high blood calcium level. And I don't know the answer to that, so my gut tells me that it probably does. I do think that taking a pill of vitamin D is not the same, even in the same ballpark of getting sunlight. I mean, it's not even in the same realm, because you're not getting any of the other benefits, right, that you're getting from sunlight. Not only the L3 and D3 analogs, which I have a whole video about, of having anti-cancer, anti-proliferative effects, anti-DNA repair effects. It has immune building effects, et cetera, et cetera, et cetera. You're missing out on those analogs that are made in the skin when you're exposed to UVB radiation. But there's all the other wavelengths of light that you're getting exposed to with the sunlight, UVA, with the POMC gene, the infrared spectrum, and its powerful effects. So you're missing out on a lot by getting from a pill. And I think that one of the reasons why we see the correlation between a lot of diseases and all types of cancer with low vitamin D is because it's really a low sunlight effect, right? I do think that taking the pill is kind of like the last line of defense, in the wintertime at a high latitude. I think that a better strategy, and again, this is a discussion between you and your doctor, would be at least having some supplemental UVB in the form of a Spurdy vitamin D lamp, exactly, or a Chroma vitamin D lamp, or a EMR Tech Krypton lamp. If you have the money for those, because they're expensive. The Spurdy is by far the oldest and cheapest, and it's FDA approved. And it works really well. It dovetails into the vitamin D app called D-Minder, which I recommend. So it's a really good tool. Now, the problem is it's got 5-minute timer, and, you'd have to do probably like 20 minutes, and, you have to work up to that, because you don't want to burn yourself. So it's going to take some time to get to the levels, because it's not like the same as getting outside in the UV index of 12 or 13 outside in the summer, right? It's not the same. But you can build vitamin D using the Spurdy lamp. And I think I would much rather a person or a family member or client use a Spurdy in a safe way than take vitamin D pills, And I think that that's just a better way of doing it. And is a Spurdy lamp as good as the sun? Absolutely not. It has some UVA. It has about a 20% UVA, 80% UVB, but it's still not the sun. And the sun is always preferred. Taking berberine and gymema, they both balance your blood glucose. Yep, I have a video on both of those substances and it looks at the quantitative amount of how they lower your blood glucose, I would say that they're probably not the most powerful, to be honest with you, of the ones we've looked at so far. Early morning red light, amen, good. And the Fuji Red Spurdy, okay? Yeah, this Fuji Red is 80% UVA, okay, and 20% UVB. So it's that light is designed to tan you. Okay, now you're going to get a bit of additional benefits aside from the tanning, right? You're going to get the POMC activation of the Spurdy Red. So I think there's benefits to the Spurdy Red. It's just that again, we're trying to biohack what's already located, in the sky, and it'd be better that it would honestly be better. I'm not a purist like Dr. Cruz is, where he's like, you need to come to El Salvador and live in a volcano until you're well. I think that is truly the best option. It's just that, there's life, and people have bills and jobs and they can't go to the tropics for, months on end to heal, even though that is probably truly the best option. Could there be some kind of middle ground there? Could it be tropical vacations several times throughout the year while you're in solar, and vitamin D winter? That would be a way to do it. Or using a Spurdy lamp and a EMR tech panel or a sauna space, system, so where you're getting full spectrum infrared, that would be a way to kind of biohack. But then you're dealing with cancer. Are you willing to settle for second or third best? I don't know the answer to that. Only you can decide that. If probiotics reduce blood sugar, would carnivore be bad? So I have been on extremes of both sides of this. Okay. I have been a raw vegan and I have been a carnivore, more carnivorous, maybe not complete carnivore, but much more on the carnivore side. And I think that both sides of the extremes have benefits. Okay. And I think both sides of the extremes have blind spots. And I think that both sides of the extremes have, kind of attract, and I've been in both sides of it. So I don't want to make it seem like I was immune to that. I think there's cult-like behavior on both sides of those. And it's like, when you look at something and it's only good and it's never bad, probably you need to rethink your belief system on that, because I do think that there's a lot of benefits, as we've seen with plant compounds having profound effects on cancer and blood glucose, and fibers and stuff like that, and affecting the microbiome. But then being on a plant-based diet, especially like some of the ones that they recommend, some of the mainstream people recommend, like an 80-10-10, 80+% carbohydrate, 10% fat, 10% protein. I think there's inherent problems with that, in particular with cancer. And if you start doing fruitarian or processed carbohydrates, in addition to that, because you're vegan, and you're doing flours and things like that, I think you're really playing with fire. So I don't think there's any one side that has got it all right. I think you can take beneficial things and pick and choose things from each of those things. And, one of the things that I think is, not talked about enough is the seafood chain, the marine seafood chain, and its importance on not only minerals, but the omega-3 long chain fatty acids your body can't make. So I'm a big fan of using kind of an epi-paleo, diet like Dr. Cruz talks about, eating seasonally. Now, I don't think that is necessarily one size fits all. I think that, I do believe a ketogenic diet is critical and foundational for people who have cancer. Do I think forever? No, but I think for cancer, I think it is. I don't know if that answers your question or not, whether or not carnivore is bad, but I think it just gives my nuance about how I look at diet in general. Northern California wintertime sunlight, not enough. Absolutely not. I mean, you may be able to get it enough infrared and red light, and obviously it's going to help balance your circadian rhythms and stuff like that. But UV, I would highly doubt it at that latitude, whether or not you're getting any UVB at all. I mean, even Weather Channel app or the D-Minder app, it'll tell you what the UV index is in your environment. And if it's less than 3, that's considered kind of 0, and you're not going to get enough to make any difference. Probably not. Ashwagandha's effect on cortisol. Yep, it does have an effect on cortisol. A lot of things have an effect on cortisol. But necessarily taking a pill isn't always the strategy, and when are you taking that ashwagandha? If you're taking it in the morning, you may actually be doing yourself harm, because depending on what your cortisol curve looks like, if you're flatlined, you're taking cortisol in the morning when it should be high or should be on, elevated, that could be problematic. So I think this is, these are questions that should be nuanced as an N=1 between you and your doctor. Cortisol could have a role, as could several other, supplements at lowering cortisol. All right. Well, we've gone an hour. I wasn't expecting to go this long, but we did. And a lot of that was Q&A. So I thank you for all the wonderful questions that we were able to field. And I hope this, I really hope this part of the series of strategies to lower blood glucose is truly actionable for you in your particular fight, because lowering blood glucose to the level we need to go to and getting your glucose ketone index down is seems to be a very big problem within people who are trying to employ metabolic therapy. And I want to give you as many tools that you have available. So until next time, and if you like videos like this, please like, share, and subscribe. Take care.